Well, good afternoon. Pleasure to be here and to share the program with two of my good friends. Here are some potential conflicts of interest. And here are my disclosures, research projects, speaking engagements, consulting fees, etc. I assure you I will try to give honest mention of the data, and not be influenced by other organizations that have helped support me in my work over the years. So here are the topics I propose to cover in the next 50 or 60 minutes. You got that, Chip? 50 or 60 minutes?
We thought it was funny.
See, they're not listening to me. They never listen to me. They're just sitting there in a daze. I put these in a little earlier this afternoon, the talks that I've heard already at this meeting, many excellent talks, and although we're focusing on physical activity and exercise, I do believe that there is such a thing as a healthy diet. I'm not quite sure we know what it is, but maybe so. But here's some research that Marianne Hero did with us a few years ago. She got her PhD just down the road, Queen's University, with Bob Ross. And I think the bottom bullet here is stuff that I heard, the kind of thing I heard repeated a good bit this morning and in the earlier sessions. So Marianne then looked at fitness in relation to those unhealthy eating indices. So here we are, go back there.
You could, I think, maybe go.
Yeah, I've got a better pointer.
Okay.
The low level of unhealthy eating, moderate, and high level of unhealthy. And then these are the low, moderate, and high fitness. And you can see, okay, there's probably a bit of a trend there for the unhealthy eating index. Don't really see much of anything here in the high fit. Maybe there's something here in the low fit. The point of this slide is fitness is a heck of a lot more important than diet. You got that, all you nutritionists? Now, we heard a lot of good background this morning on diabetes and factors affecting diabetes, and everyone in the room knows far more than I do about these mechanisms, the physiologic mechanisms, biochemical mechanisms, but I do think there are several ways in which physical inactivity can affect this pathway. And what did I do? I said, well, there are some other factors that we do always need to keep in mind. I want to go back, and this was already mentioned, the Finnish study already mentioned this morning at least once. So you're all familiar with these data. You know that those in the intervention group did better over time. But the thing I really liked about the Finnish study, see, the weight loss, okay, that's good for you. But even if they didn't lose weight, whether they were in either group, they did a whole lot better if they were physically active. Okay, I'm biased, I admit it. But my topic was to be fitness and diabetes. I'll start with a report from our colleague Susumu Sawada. I studied the Tokyo Gas Company over the past many years. So this is one of the relatively few big databases that has an exercise test, so measure of cardiorespiratory fitness. It's a submaximal test, but still that's at least a laboratory measure, and you can all read the other items on the slide. So here are the main findings: low, moderate, and high fitness and BMI. My God, they've really got a lot of fat people there in that Tokyo Gas Company, don't they? Look at this high category, BMI 23.7. Here, this still even a bit of trend in these tiny, skinny Japanese guys, but certainly a trend here and here across fitness categories. One of our reports published now several years ago, this in a group of women in the aerobic center longitudinal study, per maximal METs by 1 max MET unit on a treadmill test. Well, you guys are nutritionists. You know what a max MET is? 1 MET, resting metabolic rate. So 2 METs, double the rest. Okay. So you see, this is a pretty steep trend. Look at the difference, fourfold difference in diabetes across these increments of fitness in this group of women. So I was debating Professor Ai-Min Lee, an outstanding scientist at Harvard University, at the American Heart Association on this crazy fitness-fatness concept that we came up with 20-some years ago. Presented the first research on that, in fact, just over there in Quebec City. I'm a really stupid guy. I was presenting it at an obesity meeting. And I said, forget about obesity, it's the fitness. What a lot of rubbish that is, I heard. So, but anyway, I was debating Ai-Min that fitness is far more important than fatness, and fitness tends to eliminate the association of fatness with health. And I was winning, of course, you can imagine. But then she nailed me. She said, well, Steve, you might be right for all-cause mortality in cardiovascular disease, but you're not right for diabetes. I'll show that woman. So I went back and told my postdoc, D.C. Lee, okay, let's do this fit-fat in the diet. And oh my God, she was right. Here in the fit guys, if they were higher fat, yeah, they did have an increased risk. So I did, of course, invite Ai-Min to help us interpret these results and publish this report. I mean, I still will claim, I think this slide also supports fitness probably is more important than fatness. And remember, this is measured fatness in the lab. This isn't BMI. But, okay, for diabetes risk of incident diabetes, fatness is a factor, no question. A couple of people, at least this morning, mentioned the Look Ahead study. And I don't think anyone showed this slide, but over the course of the trial, this group fell off of it. But they were still more fit after 4 years of follow-up than those in the, control group. John Jakizek sent me this slide the other day, published a couple of years ago. So this is the diabetes support and education and the intensive lifestyle group. So in both groups combined across decline in fitness, 0 to 10%, well, you can all read. So across fitness groups, also in the diabetes and support and education group, and in the intensive lifestyle. Again, fitness is important in reducing the risk of developing diabetes. So let's get to fitness and mortality. First paper we published on this now 15 years ago, follow-up again of a group of men, all of whom had physician-diagnosed type 2 diabetes at baseline by either of those measured. So followed up for several years, 180 deaths over that time. And when Ming showed me the data, I said, oh yeah, boy, look at that, fitness is, and it's actually a lot more important. Now, obesity or a BMI is associated. You know, this is not, there's a bit of a trend there. But, I mean, look at that, 60% lower risk, 80% lower risk. He said, oh my goodness, that looks pretty powerful. But does that apply when you consider other health risk factors? So this is another slide from that paper. Whether it's, again, we've already seen the BMI data, blood pressure, high cholesterol, smoking status, baseline fitness or not, family history, and whether they have diabetes. You know, in all these cases, fitness does seem to be important. So then, a couple of years after that, young Tim had joined us, a few years before then. And so Tim decided to look at fitness, fatness, and mortality. And at that time, we had almost 2,200 men with type 2 diabetes, again defined as such, 275 deaths during the follow-up period. Here's the finding from that study. These are the curves of the guys who were at least moderately fit. and these were the guys unfit. And the way we've been defining it over the years, unfit, excuse me, is the bottom 20% of each age, gender category. So these are not marathon runners. They're just out of the bottom 20%. And we've called them moderate or high fit. And you can see the fit curves, whether the person is overweight or obese or normal weight. The fit guys were less likely to die. The unfit guys were more likely to die, whether they had a high BMI or not. Then he followed that up. We got a few more cardiovascular disease deaths. I've shown this slide, Tim, 1,000 times around the world. It's one of my favorites. So again, these men with diabetes, 179 cardiovascular disease deaths during follow-up. Now, I don't know how it is here in Canada or in Norway or wherever you're from, but I can tell you, in the United States, it is impossible to escape the doctor's office without getting weighed. I try every time. Say, well, you don't need to weigh. Come on, fat boy, get on that scale. So they're going to weigh you, measure your height, and calculate your BMI. You cannot escape without getting your BMI calculated. So here in the normal, by BMI standards, low, moderate, and high fit, look at this risk of cardiovascular disease. In the overweight, now there aren't a lot of obese guys who are high fit. If you put your imagination to work and think about it, there is one in this room. So, Tim, because as we do in epidemiology, not enough in the high fit category, so combine the moderate and high fit. So they're at least moderately fit, and look at that difference in risk of cardiovascular disease death. In fact, look at the difference here in the fat guys who are at least moderately fit, who have diabetes, and compare that risk to these guys who are normal weight and unfit. Is it possible, in Norway, for example, can you escape a medical visit without having an exercise test and your fitness measured? Yeah. Is that true in every single country? In the United States, what percentage of medical exams include a fitness diet? I don't know, but you could count the percent on, well, maybe, it's not very many. You can't get out without having this done. What's important here? If you have a patient with diabetes and you want to know their risk of dying in the next few years, what's important, BMI or fitness? You can all read. Paul Macaulay, a little bit after Tim's work, followed a different population. Now, some of you may know the Cooper Clinic population that I've worked on all these years. They're mostly non-Hispanic whites. 80-some% of them have college or graduated from college. They're business executives, lawyers, doctors, et cetera, et cetera. So they're quite a lot different from Susan Musawado's Tokyo Gas Company guys, who are all blue-collar Japanese, and you can lay his results right on ours. So I would say the veterans study that Paul, John Myers, Peter Kakinos have been working with, so that's a pretty different population than the Cooper Clinic population. But I think, you look here at the survival curves, looks like, yeah, maybe the association's pretty much the same. Whether you're a retired U.S. veteran, probably if you're in this study and you go to the veterans for your medical care, you're probably not the business executive or professor or lawyer, doctor, what have you. So then we worked with Paul and recently, just a little over a year ago, looked in the ACLS database on fitness, fatness, and survival in adults now with pre-diabetes. So the men and women in this analysis, you can see these are the factors of this particular study published in Diabetes Care last year. And here are the main results. Kind of a complicated slide and a little hard to see some of these numbers in the back. I apologize for that. But these are the fit men and women. The reference category, of course, the fit, at least moderately fit, a normal weight individuals. Well, there's no difference between the risk of dying across the overweight or obese category. Now, there aren't a lot. I mean, I am not the only fat guy, obese guy who is fit, but there are some. The numbers are smaller, but no elevated risk. And then you look at the unfit ones, and all of these are at higher risk of dying. And the results, again, here we have waist circumference, we have percent body fat measured in the lab, and the results are all pretty much the same. So that's why I think fitness is a very important determinant anytime we discuss diabetes, or in fact almost any health outcome, even including, what is this disease that affects?
Stroke?
No, brain.
Brain, yes.
Dementia. Dementia, yes, I'll remember that eventually.
Yeah.
But we have published on that.
Well, there's 3 signs of a dementia, you know. The first is
forgetting. So, of course, again, I'm biased. Fitness is important for just about anything. So how should we deal with the diabetes? Obviously, I think we need a lot of focus on activity, because what is fitness? It's just a marker of what your physical activity is. And to get out of the low fit category that I've been discussing, what do you suppose you have to do? 150 minutes a week, moderate intensity activity, etc. You don't have to run marathons or compete in triathlons like Dr. Church does, or at least has done, but get that 150 minutes a week. So how do we get people to do that? We do need to understand energy balance much better than we do. I know probably most of you are from the nutrition field. I respect nutrition, but there's far more emphasis on nutrition than there is on activity for any health outcome. I think the distinguished person, the lady who opened the talk this morning, she went on and on about sugar, and she mentioned fast foods, et cetera. So that's what we're bombarded with out there in the mass media. And go to PubMed and search physical inactivity and obesity, diet and obesity. You will see many-fold difference. I want to see more balance on energy balance. Then I want us to design interventions to address these problems of healthy eating and physical activity at the population level. She mentioned this. Why am I picking on her? Let's put on the menu, let's require restaurants to put the calories. I'm not opposed to letting people, I think that's fine. When New York City did that, she mentioned Mayor Bloomberg, do you know what happened, at least to the research I've seen? Do you know what happened to caloric intake after that? It went up in New York City. It worked in the wrong direction. So let's test these things, the public policy, education programs. Let's see what works. And you want me to tell you the solution to the world's non-communicable chronic disease problems? Learn how to use modern technology to help people practice healthful lifestyle. There'll never be enough doctors, nurses, dietitians, exercise, never be enough. But we have learned about behavior change. We have learned some of the things that work. Let's apply them with modern technology. And this is a new area of research that we've got a big center at our institution. So, of course, I'm keen on that. And then let's implement these successful interventions. And finally, back to energy balance, let's have more balance in science and in media, in meetings like this, etc. So this is a new project, relatively new, the Global Energy Balance Network that Jim Hill and I came up with some months ago. Go to the website, take a look. We're still in early days. Send us advice, tell us how to improve it, and sign up to be a member. You can, no cost, no charge, just sign up to be a member. So, and seriously, we do welcome comments on how we can improve the website and improve. We really only want 7.1 billion members. we'll exclude 0.2 billion. And you know, so we don't want to reach everybody. We do want to reach a lot of people. Help us do that. Thank you.
It's such an unbelievable honor to be up here with Steve and Chip. They both have played such a huge role in my career. And you know, when you mentor people, it's often an enormous pain in your, you know what, and sometimes it turns out okay. And I wouldn't be here without both those two guys. I love to tell the Chip story. When I was a third-year med student, I called the cardiologist, kind of big, famous cardiologist in New Orleans, and I said, I'll do some research. And finally get into his office. I walk in, I'm in the office 30 seconds. He looks at his research nurse, he says, whatever he wants, give it to him, and he walks out of the office. And that was probably 20 years ago. And of course, Steve, I worked with him at Cooper for years and years and years, and it was just such a pleasure. And a lot of what I'm going to talk about today was actually Steve's ideas that I've stole. Years ago, most organizations that had something to do with health, and particularly health and diabetics, they had these proclamations. They said the best exercise recommendation for people with type 2 diabetes is to go get your 150 minutes of walking and then go weight train 2 days a week. And guess what? I mean, ADA did this, Surgeon General did this, CDC did this, everybody did this, and there was no evidence to support it. It was actually really cool. What there was there evidence that aerobic was good for you and that resistance training was good for you. So heck, if you do both, it must be even better for you, right? And at the time, there was actually a very vocal group that said people with type 2 diabetes should only be doing weight training. And there was some convoluted logic behind it, but nobody at the time had ever tested what's better. If you take a type 2 diabetic, if you tell them to go lift weights, or you tell them to go walk, or you tell them to go do both, who's going to get the most health benefits? And that's a pretty important question, I think. Well, now there's been 3 studies done. 2 of them were actually done here in Canada, and the third was heavily influenced by what the Canadians did, and that was our study, Heart-D. So it's really fun to actually be here talking about this subject, given so much of the research has been done here. The first one is out of Dr. Siegel's group, the DARE trial. I like to call it the DARE trial, eh? And I had to look up how to spell that. It's a fantastic piece of work, which was so ahead of its time, and thank goodness it came out when it did, because it allowed us to modify our research design based off of their results. It was 251 individuals with type 2 diabetes. Insulin use was an exclusion. You can see the hemoglobin A1C criterion. Very simple design. One group got aerobic, one group got resistance training, one group got both, and one group got, well, nothing. And hemoglobin A1C, then a whole bunch of other secondary outcomes. I'm sure you guys have seen this. I do want to make the point, you know, there was some caveats. With all trials, you have to make certain decisions. And you live with those decisions, and then people criticize you about them. And in this instance, you know, they don't change your diet, and then don't change your medications. This is important in diabetes because an individual's medication, their use, really impacts their hemoglobin A1C and their blood sugar control. And they took the route, and I get why they did it. Don't change it. And this is what they saw. So the control group stayed about the same. The aerobic group improved. The resistance training group improved about the same, but the aerobic plus resistance training group really improved. So essentially a 1-point improvement in hemoglobin A1C, which is actually better than most of the medications. We don't really like to talk about that stuff, but it's true. It's a remarkable improvement in hemoglobin A1C. This was a 6-month intervention, if my memory's correct. And then, you know, every study has its own set of strengths and weaknesses, and if you were to assess the strengths and weaknesses of this particular trial, it was primarily Caucasian, 92% Caucasian, 70% men. Again, the no insulin users, which makes it a little bit of a healthier group of type 2 diabetics. So everything you see there is the polar opposite of what we see in the Deep South. And so it's important to expand this results to other populations. And I think this was the biggest I don't want to say complaint, criticism. And I think it was an unfair criticism. I understand why they did this. But I thought people went too far with this, almost getting a little dismissive about it. The exercise dose was additive. So the aerobic group did about 135 minutes a week. The resistance training group did 135 minutes a week. The combo group did both. So now you're talking about a huge dose of exercise, 270 plus minutes per week. And again, I understand why they did this. Make perfectly good sense to me, given what we knew at the time. But there's definitely was a lot of criticism about this. Did the interventions make a difference, or did the raw time in the gym make the difference? That was the argument. I also want to mention just briefly, this is out of Bob Ross's lab in Kingston. Lance Davison was the first author on this. This wasn't in type 2 diabetics, so I'm not going to go into great detail about it. But it was the same thing. It was aerobic compared to resistance training compared to both. Older adults looking at both functional capabilities and insulin resistance. I think these were clamps. No, I don't think these were OGTs. I don't really, whatever. The bottom line is that doing both the combination was better than either of them alone. It was another beautifully done paper. I consider this the second of the three. And then the third of the three is ours, Heart D, health benefits of aerobic and resistance training in individuals with type 2 diabetes. It was published a little over 5 years ago now, which is just unbelievable to think of. And it was 262 individuals with type 2 diabetes. Hemoglobin A1C greater than 6.5, but less than 11, sedentary. And again, there was 4 groups. There was a control group which had stretching available to them if they wanted to come in and stretch. There was a group that did aerobic exercise, basically the 150 minutes a week-ish. There was a group that did resistance training, so 3 days a week, about 21 sets per day. I'll put some more metrics around this. Our combination group did a little bit less aerobic and a little bit less weight training. The goal was to try to have everybody be in the gym about the same amount of time. We got really lucky on this because when we did the combination group, we did that before the new federal physical activity guidelines came out. When they came out, they perfectly aligned with our combination group. So it was a real nice test of kind of the new guidelines, which had been started before the new guidelines even existed. It was a 9-month exercise intervention. Why 9 months? Because I anticipated we were going to have to train these people to train these people. That they were going to be so out of shape that we had to train them up a little bit before we trained them. And sure enough, that was. Just to give you guys a sense of the fun of doing these studies, we monitor every heartbeat, every step, every weight, everything. This was over 20,000 supervised exercise sessions. We've got all the data. We know exactly what these people did. And these are huge team efforts, and I'm very blessed to have an amazing team. Primary outcome, of course, hemoglobin A1C. It's such a great research tool because it's such a great clinical tool, and many secondary outcomes. I'm timing myself because I'm really not good at keeping track of time. Mean age 56, 63% female. Only half our population was Caucasian. The other half was primarily African American. This study was done in Baton Rouge, Louisiana. Just on the edge of class 3 obesity. On average, people had hemoglobin A1C a little over 7 years, and you can see they were very, very unfit with a VO2 max at 19. Of course, that was measured. Approximately 18% on an antidepressant, probably a lot more who needed to be on one. Around 20% of individuals have a history of cardiovascular disease. They had had a previous MI, they've had a cath, or they've had a bypass, and about 17.6% had neuropathy. The bottom line is if you could possibly exercise, you were in this study. We did not cherry pick at all. It was scary as hell, I'm not going to lie to you. Because some of these people are like, really? We're going to exercise that person for 9 months? They can't even make it down the hall. But we enrolled them. And that was to be as inclusive as possible. I was really surprised by how well medicated they were around cholesterol and blood pressure, given that we were in southern Louisiana. But they were. On average, people were on just short of two medications to control their diabetes. And we had 94% follow-up. That means that of the individuals that came into our trial. We had follow-up data on 94% of them. The ones we lost were typically, and this is not meant to be funny, it's going to sound crazy to you guys, displaced by a hurricane or lost the job and moved to Houston or Atlanta or something. So we did a remarkable job of follow-up. Again, it's the team. We tell the story, and this is a true story. We went out and drew blood in a barber shop of the guy who owned the barber shop, who had a loaded gun next to him as we drew his blood. And I always tell my team, I said, whatever it takes, just get it done. I don't want any excuses. And I heard the loaded gun story. I said, people, we have boundaries. You just crossed it. When I say whatever it takes, it doesn't involve guns. But I want to make the point when you talk about compliance, 72% of individuals were compliant to the aerobic, 82% to the resistance training, 82% to the combination. This is fascinating to me because we've done a lot of trials, a lot of big trials, and we get really high compliance with aerobic. This was a really, really challenging group from an aerobic perspective because they just were kind of done with us. They got fit after 3 or 4 months. They just were like, we're done. This was fun. See you later. And we struggled to keep the aerobic group in. The resistance training group blew me away because I was still doing exams then. I do the baseline and exit exams. And I would do the baseline exams, and the women would always say the same thing. They would say, don't put me in a weightlifting group. I don't want to look like those women in the magazines. I'm like, okay, well, you're not. But it's not my decision, it's the computer's decision. And then ironically, once the women got in the weight room, we couldn't get them out. They loved it. They had more function in the rest of their lives. Their quality of life was going up. Their arms are toned, their shoulders were toned, their legs were toned. They loved it. It was fascinating to me how that was a very easy 82%. And same for the combination group. That was a fairly easy 82%. So this is a little bit of a side note. I keep thinking about maybe we need to be doing weightlifting to trick people into doing aerobic. Is saying, look, you want to do your weightlifting, that's awesome, but let's warm up first, 10 or 15 minutes on a treadmill, and go do your weightlifting, and then give me 10 or 15 more minutes warm down. And you know, particularly in big individuals, because they're going to be really strong and they enjoy it. It's empowering. That's neither heart. And this is another point around the weightlifting. And I know you can't tell because they're still getting stronger at 9 months. That's fascinating to me. First in the beginning, because you're ramping them up. But look at that over 4 months, that huge increase. But they're still getting stronger at 9 months. That's very encouraging. Focus on this. We let people choose their intensity. So on average, they came in 3 days a week, moderate to vigorous. These are really out of shape people, but we see this time and time again. People want to exercise at a higher intensity so they can get out of there quicker. Because this is sheer calories. It wasn't time. It was how long it took you to burn so many calories. They didn't increase speed. They increased the grade, which increased the METs, which decreased the amount of time that they were in the lab. And this is we got really lucky on our guesses. When it was all said and done, the resistance training group was in there about 1 hour and 41 minutes. The aerobic group was in there about 1 hour and 40 minutes. And the combination group was in there about 30 to 40 minutes. And the aerobic group, the aerobic element of that was 110 minutes. So all groups were in the gym the same amount of time. So time's not an issue in this particular analysis. And here's the results. So what we have here is monthly hemoglobin A1C by group. And you see the control group, they actually get worse over time. And this is a point I always make with my younger researchers, is that when someone has metabolic syndrome or someone's at a risk for disability or someone has type 2 diabetes, if you do nothing, they're not holding serve. They're getting worse. Doing nothing is making them worse. Matter of fact, they were doing so bad, our DSMB shut down our control group halfway through. So the control group has half the people the other groups do because it become unethical to keep enrolling in a control group. The resistance training group got a little bit better. The aerobic group got even more better. And the combination group did the best. And this is why you do these studies, because I didn't see this coming. I thought for sure the aerobic and the combination group were being right on top of each other. And our story was going to be, it doesn't matter what you do. But clearly, from a hemoglobin A1C perspective, there's benefit to doing the combination. Time on treadmill, you heard this from Steve, you're going to hear this from Chip. There may be nothing more important as a risk factor than how well you do on a fitness test. And this is raw time on treadmill, because it's always fun to look at this before you start talking about METs or VO2. But on average, 20% increase, basically 3 more minutes on the treadmill in both the aerobic and a combination group. That translates into a MET. So what does a MET mean? Why do we keep talking about METs? Well, because if you translate that into risk, in this particular group, because they were so low in fitness to start with, a MET translates into a theoretical reduction in cardiovascular disease of 36%. So we get really excited about lowering cholesterol and going from 16 to 12%. Now we're talking about a 36% reduction. Of course, strength training, we measured this with the Biodex, no surprise. The group that got the weightlifting, they just blew it out of the water. But this is fascinating to me. The combination group, they're only doing 2 days a week. And they're only doing basically 1 or 2 loops of the whole circuit. It took 15, 20 minutes. They not only didn't lose strength, they gained strength. And then weight. This is raw weight. You put someone on the scale and you weigh them. The resistance training group, nothing changed. The aerobic group improved their weight a little bit, but the combination group improved their weight a lot. You're thinking, well, weight is just weight. It doesn't tell us anything about fat or muscle. Well, we had DEXAs. If you look at the weight training group, of the weight they lost, or what happened was they added muscle, lost fat. That's why the scale didn't change. Good message there, fun message. Aerobic group, they saw what you see with weight loss. It's a combination of fat and muscle. You know, people like to talk about fat loss when you lose weight. Actually, generally when you lose weight, you're losing about 1/3 muscle and about 2/3 fat. And that's pretty much what we saw here with the aerobic group. But look at the combination group. What they lost was exclusively fat mass. Again, they didn't do that much weightlifting. I think there's a real positive message here. And then, so summary point number 1, I do believe the optimal exercise program for individuals with type 2 diabetes or prediabetes or metabolic syndrome is a program composed of both aerobic and resistance training. In this instance, it was about 100 minutes a week of walking and around 20 minutes per day, 2 days a week of weight training. Remember, the guidelines say 150 minutes a week of walking or 75 minutes a week of jogging. The higher the intensity, the number comes down. Well, they weren't quite slow walking and they weren't quite jogging, so that's why the 100 minutes a week gets it done. And I want to make one more point of some new research coming out of Bob Ross's lab, again, because he just does such amazing work, and I think this is one of the most important exercise trials that came out in the last 10 years. And you know, I just mentioned the guidelines. They say that the health equivalent of 100 minutes a week of slow walking is the equivalent of 75 minutes a week of jogging. So intensity doesn't matter from a health perspective. And all throughout the guidelines, it says we don't have enough research, we don't have enough research, we don't have enough research around intensity. I think this is the best intensity paper that's ever been done. He randomized people to the same dose of exercise but different intensities. And I want to get to the point. So this is the control group. This is low intensity, low dose. This is low dose, high intensity. This is high dose, low intensity. This is high dose, high intensity. And from OGT, glucose control, these are not diabetics, clearly additional benefit for a given dose of exercise doing higher intensity. We've been talking about fitness. It's same thing here too. The group that did, these two groups did the same dose of exercise. These guys just did it at a higher intensity. Higher intensity means they're there fewer minutes. That's a good thing. And they improved fitness even more. So just to break it down to the bottom line, whether you're talking to a group or talking to an individual, I like to figure out where people are at. And if I'm not interested, I don't want to talk about this exercise stuff, I'm out. I say, hey, sitting's bad for you. So you know what? Get up every 45 minutes for me. Every 45 minutes, get up for me. I don't care how much you sit throughout the day. I want to avoid the prolonged sitting bouts. Get up for me every 45 minutes. I hear you, but I'm not going to exercise. Okay, give me 7,000 steps. 7,000 steps a day, get a step counter, get a fancy Fitbit, get a Jawbone, get whatever you want, 7,000 steps a day, and use the stairs when possible. They tell me, all right, I'm willing to exercise, but I don't know about this weight training stuff. Well, in that case, go to the prescription, 150 minutes a week of walking, or 75 minutes a week of jogging, or 100 minutes of fast walking. Someone's seen the light. Their brother had a heart attack, they're scared, they want the ultimate exercise program. Okay, first, go get clearance. Make sure you don't have any risk factors you don't know about. I want a higher intensity aerobic program, maybe some intervals. We're going to hear about that in a little bit. Plus, at least 2 days a week of weightlifting. The weightlifting makes sense because age 40, 50 on, we lose 1 to 2% of muscle a year. how well you can lift things is critical to quality of life. When you're in your 70s and your 80s, can you lift your grandkids? Can you carry your own luggage? These are quality of life issues. That's where the weightlifting becomes so important. I think I'm a minute ahead of schedule, so thank you guys very much.
I'd like to say from the outset, my only disclosure for this talk is that I'm the author of this book called The Obesity Paradox, and I have no other disclosures. But if any of you are interested in adding to my disclosure, just please go on obesityparadox.com or check out amazon.com or maybe head over to Barnes & Noble. And I'd be glad for my conflict to increase. Well, this has been an important topic. I was asked several years ago by JACC, which is our leading cardiovascular journal, to write a state-of-the-art on obesity and cardiovascular diseases, including the obesity paradox. And, you know, a lot of times when you have an original research article come out, there's especially if it's a new finding, you get a lot of press. Well, this was just a state-of-the-art review. And after this came out in 2009, I probably did over 200 interviews in the next month and led to tens of thousands of write-ups in the press showing that this is a topic that's of substantial interest, not just to scientists and clinicians, but also to the lay public. And this paper, by the way, I know it hasn't caught any of Dr. Blair's papers so far, but it's almost up to 900 citations in the literature. And then this past year, I took over as editor in January 2014 of the journal called Progress in Cardiovascular Diseases. And my first issue was on this whole topic, if anyone's interested, on obesity and cardiovascular diseases, not just the effects that obesity has on cardiovascular structure and function, but also on prognosis, including the obesity paradox. And a pretty famous guy in Canada, J.P. Disprace, was one of the authors of one of these really, really good papers. And what I'm talking about today, we recently reviewed with Tim Church and Steve Blair in an issue on exercise as medicine in U.S. endocrinology, and a lot of what I will discuss is in this paper. Well, to start off, I think there's a lot of controversy on what causes obesity in the first place. And certainly the press has really put a lot of the blame on the fast foods, McDonald's, Taco Bell, Burger King, and on the diet, including carbohydrates, the sugar, the sugary beverages, have all gotten a lot of blame. Well, my colleagues and I really believe that the fundamental cause of obesity is the very dramatic decline that's occurred in physical activity over the last 5 decades. And this is a paper that Steve Blair and Tim Church and I all published together in PLOS One. It came out in February 2013, and it got a lot of publicity. And it wasn't all, and it was a study that assessed women's household management. First author was Ed Archer. And so basically measuring housework that women did over 5 decades. And in one of the news clippings, it had a picture of me in the paper, and next to it, it said, "Women are getting fat because they're not doing enough housework." So you can imagine how well this went over on the home front. Our paper was on Fox News 3 times in one night. And I don't know how many of you watch Fox News, but it's on all night at my house in New Orleans. And we were on the Jay Leno sitcom. You know, and my daughter was a medical student, came home and told me that my sister, who was a social worker in New Orleans, was very upset about my paper. But basically, our paper showed that over 5 decades, there's been dramatic decline in the energy expenditure that women are doing in-house. basically on the tune of 1,860 calories per week on average. Now, it's more complicated than this, but we typically use the term that about 100 calories are burned for every mile traveled by foot. Now, we've actually published papers that that's not so accurate, but that's still a good general way to think about it. That's the equivalent of basically walking or jogging 18.5 more miles per week to make up now for the housework that wasn't being done as it was 5 decades before. Now, Tim Church, in a paper a year or two before that, looked at occupational physical activity. And unlike our paper that just looked at women, he looked at both women and men occupations and basically showed, as you'd expect, over 5 decades, very dramatic declines in the physical activity. And when you look at what's happened to the occupational physical activity over 5 decades, and you looked at what's been the prevalence of obesity, it almost exactly tracked the increased prevalence of obesity correlated with the reduction in occupational physical activity. And in December 2013, Ed Archer and I and Steve Blair assessed maternal physical activity. This first slide is in women with older children above the age of 5. Again, very marked increases in sedentary time and reductions in activity time. And it's even more marked in the women with younger children. Now, this may be important not only because it affects the weight of the women, but there's a lot of evidence that the hand who rocks the cradle rules the health of the next generation. So it may actually have an effect on the offspring. And then the fact that the greatest contributor of fitness, which I'm going to discuss and Dr. Blair discussed, is physical activity. So all of this makes a very significant tie-in. And again, both in the women with older children and even more so the women with young children, it adds up to about 1,600 calories less per week that are being burned now compared to 5 decades ago. So in the setting of low physical activity, yes, it is important that one has to reduce the calories from all sources, including carbohydrate and sugar. But the fundamental cause of obesity and the weight gain that's occurred over time is not the calories or the fast foods or the sugary beverages. It's the very marked decline in physical activity. Now, there's also controversy on how much obesity is playing a role in decreasing the health and survival of our nations. And this is data that Catherine Flegel of the Center of Disease Control in the United States published in JAMA in January 2013. It's a meta-analysis of 97 studies of 2.9 million people with over 270,000 deaths, so a lot of statistical power. And they showed in this paper that relative to normal weight, the obese, if you count all the grades, the mild, the moderate, the severe, they had an increased mortality, statistically significant. But it was particularly the class 2, which is BMI between 35 and 40, and class 3, a severe obese, BMIs above 40, that carried all the weight, no pun intended, of the increased mortality. Whereas grade 1 obesity, which is BMI between 30 and 35, was actually associated with a strong trend for lower mortality, a 5% lower mortality that was almost statistically significant. And the overweight BMI between 25 and 30 actually had a 6% statistically significant lower mortality than did those with the normal BMI between 18.5 and 25. And if you looked at the older people, BMIs above, age above 65, I think you might fall into that class. Do you, Dr. Blair? What, by about 30 years? But the older individuals actually had only a non-significant trend of 10% higher mortality, even with BMIs above 35. And that wasn't statistically significant, and there was no even trend with lower BMIs. So it really raises the question, how much is particularly overweight and mild obesity playing to the adverse survival? Now, this just looked at survival. This didn't look at quality of life. This didn't look at arthritis. This didn't look at depression. This is just survival. And clearly we know that there's substantial evidence that fitness is important. Dr. Church and I were on this American Heart Association statement in circulation a couple of years ago showing how important fitness is and why we need a registry for fitness. And certainly numerous studies show a very strong relationship between measured fitness and subsequent survival. There was a big meta-analysis of studies by Kodama and JAMA about 5 years ago that basically showed for every 1 metabolic equivalent change in fitness or exercise capacity, total cardiovascular disease events was affected by about 15%, and cardiovascular and total mortality was affected by 13%. So an extremely strong finding. Dr. Blair showed this slide already about close to 9,000 people, and incidence rates of diabetes by going low to bottom 20 percentile, moderate to middle 40 percentile, and high to top 40 percentile, a very strong trend for lower development of diabetes with higher amounts of fitness. And Tim Church showed that even stronger findings in a very large study of 13,000 people, a very strong relationship between diabetes prevalence and increased fitness. And if you notice, the biggest bang for the buck is not getting out into the super high levels of fitness, but it's moving one out of the low levels of fitness into the next lower categories of fitness. Just a little bit improvement in fitness dramatically reduces the incidence and prevalence of diabetes. Now, he showed this paper, too, in fitness and diabetes of 1,263 men, followed for 12 years. It had 180 deaths, and showed that men in the bottom 20 percentile of fitness had a 2.1-fold increased mortality. Now, physical activity also played a role. The low physical activity was 1.7-fold, but it shows that generally, when studies assess both physical activity, and at least the old studies that assess physical activity were by questionnaire, so that's not as accurate, that fitness is a more precise measure and a much stronger finding. Maybe if currently physical activity was measured more precisely, as Dr. Blair mentioned, with pedometers or smartphones, Fitbits, we might see a little bit different story. But still probably I would predict that fitness would be a stronger predictor. Tim Church's data in 2,300 men with diabetes, followed again for 16 years, had 179 cardiovascular deaths, showed that men with low cardiorespiratory fitness in the bottom 20 percentile, it didn't matter what they weighed because they had a close to 3-fold increase in cardiovascular disease mortality, whether their BMI was normal, overweight, or in the obese category, as shown here. And again, a very strong relationship, as Tim Church showed, between fitness and subsequent mortality. And again, you get a progressive reduction in mortality as you improve your fitness, but you get a very significant bang for the buck by just moving out of the lower categories into the next or the next lowest categories of fitness. And again, when you combine fitness and the fatness material, that the fitness, regardless of your weight, appears much more significant than fatness. And many other landmark studies that Steve Blair has been involved with, from the Aerobic Center longitudinal study and elsewhere, have shown these same findings, that fitness seems to be more important than fatness for predicting long-term outcomes. In my first issue of Progress in Cardiovascular Diseases, Steve Blair and one of his colleagues, Von Barry, did a meta-analysis of this. They analyzed 10 studies that were prospective and jointly measured both fitness and adiposity, or basically body mass index, and compared with the normal weight fit, the unfit, which was generally defined as the bottom 20 percentile or the bottom 30 percentile, had basically twice the all-cause mortality, regardless of their BMI. And the overweight fit or the obese fit basically had similar survival as did the normal weight fit. So they concluded that fitness was more important than fatness for long-term mortality. Now, clearly, the higher the weight is, as you start getting extremely high BMIs, It's going to be very hard to be fit. But there are a number of people in the overweight and mild obese categories who are more fit than the lean. And I know there have been some heavy people that have passed me in races for the last 20 and 30 years. And it's humbling. Both Dr. Blair and I have had the pleasure of working on a lot of papers with D.C. Lee, and one of them that we did a couple of years ago measured change in fitness and fatness in about 5,000 people. This is a paper in Circulation, but another one that was published in JACC looked at change in fitness and fatness over time and the prediction of hypercholesterolemia, metabolic syndrome, and diabetes, and basically showed that both increasing your weight over time or lowering your fitness over time were predictors of developing these adverse sequelae. But fitness was considerably more important than fatness for predicting these endpoints. And in this paper in Circulation, in over 10,000 individuals who had assessments twice over time in fitness and BMI, he showed again that both BMI increasing and fitness falling were associated with increased cardiovascular disease mortality and all-cause mortality. But in this paper, he showed that once you assess the change in fitness, the change in fatness no longer had any statistical predictability. So again, change in fitness was more important than fatness. So in a perfect world, everyone should remain lean and fit. But if you're going to give up one with aging, it's much better to gain some weight and to maintain your fitness. In this paper, he showed that for every 1 MET change in fitness, there was a 19% change in major cardiovascular disease mortality and a 15% change in all-cause mortality. And again, many studies are showing that this finding is actually much more important with aging, that there's a much more U-shaped relationship between survival and BMI at higher ages than it is at low ages. Now, with regard to diabetes, I know of 5 major studies now that have shown an obesity paradox, and I've actually published a lot on the obesity paradox in cardiovascular disease. I've shown it with coronary heart disease, heart failure, hypertension, atrial fibrillation. But these are 5 papers that looked at the obesity paradox in diabetics. And 4 of the studies showed a strong obesity paradox. The first one was by Carnington and JAMA in 2012. The second one was by Logue in Diabetes Care in 2012. The third was by Zal in Circulation in 2014. And just a month ago, Costanzo showed it in Annals of Internal Medicine, meaning that in diabetics, the lean diabetics are having a worse prognosis than those who are overweight and mildly obese. And 4 of the 5 studies have shown this. The only one that didn't was the one by Tobias and colleagues in New England Journal of Medicine 2014 from the U.S. Nurses and U.S. Physicians trial from the Harvard group, and Dr. Blair, Church, and I all published a letter to the editor criticizing some aspects of this study. But certainly, not only did this study, but the other 4, none of them assessed adequately physical activity or cardiorespiratory fitness. Now, there was a big paper in JACC by Bell and colleagues several months ago that assessed that the obese individuals who were metabolically healthy, meaning they didn't have diabetes, they had good sugars, good blood pressure, good lipids, over time, the obese developed more abnormalities. Well, we have a paper coming out next month discussing how the lack of fitness really affects this. And in a recent paper in Nature's Reviews in Endocrinology, I reviewed the whole aspect of healthy obesity and the obesity paradox, and particularly how it's very important to tie in fitness, because without information on fitness, you really lose a lot of important information about obesity and prognosis. And again, the key is not just becoming fit, but trying to get people out of this low fitness category into the next lowest categories. You get the biggest bang for your buck by just seeing a little bit improvement in fitness. And as Tim Church showed, resistance training is also important, particularly as you age. We had a paper, one of Dr. Blair's fellows, Enrique Arturo, a couple of years ago, showing how strong muscular strength is as a predictor of cardiovascular disease risk factors and all-cause survival. And so it's very important to combine both the aerobic training and resistance training. And in one of our Heart D papers that one of Tim Church's and my fellows, Dr. Neil Johansson, recently published in Diabetes Care, showed that the combination of aerobic training or aerobic training combined with resistance training both increased the exercise capacity by over a MET and got over a 20% improvement. Now keep this in mind, in the look-ahead trial, at the end of 4 years, the difference between the intervention and the treatment arm was only 0.3 METs. So that's not much of an improvement in exercise capacity. So in conclusion, I think the data that Dr. Blair and Church described as well really supports that physical fitness is an important component of health and overall health-related quality of life. Cardiorespiratory fitness may perhaps be the strongest cardiovascular risk factor. And in fact, people with hypertension, hypercholesterolemia, metabolic syndrome who are fit often have a better prognosis than individuals who don't have these disorders who are unfit. And although in a perfect world, everyone would remain lean and fit forever, in the fit versus fat debate, fitness seems to be considerably more important than fatness, and this pertains to type 2 diabetes as well. And so certainly greater efforts are needed to assess and improve fitness in both endocrinology and certainly in all of our efforts in preventive cardiology. Thank you very much.
The study is about a new training form who may improve glycaemic control and also pancreatic beta cell function. I think that developing or the causing of diabetes is, of course, many characteristic. Of course, as we have been here today, also about the food intake is a very hot issue. Obesity also, but also, of course, training is one of the parameters that we should be aware about. Finally, of course, smoking, as we all may know. But in this this lecture, I would like to keep focused especially on exercise. The reason to conduct this special high-intensity training program is that it has shown that the people have more enjoyable by doing this kind of training compared to normal, more moderate training. We know also that skeletal muscles, metabolics, and also oxidative capacity also have been increased, have been shown in several studies also regarding this kind of training. Glycaemic control and also pancreatic function seems all to be improved with more intensive training, in fact. They have been shown that it has improved cardiovascular function, not surprising, and also that GLUT4 proteins and also for the mitochondria, the mitophosine 2 have also been shown to be changed a lot during only 2 weeks of this kind of HIIT training. And of course, we know also we have also been aware about that HIIT training may also increase the production of catecholamines, mainly dopamines, which may have a very beneficial effect, especially on the abdominal fat metabolism. So, and at the end, I can just say what is maybe the most important thing of it is that it's possible to do this kind of training for this group of patients here, because its limit time is only half an hour it takes from you arrive to you go home. So you can do it very easily beside your work and also fit it in the daytime. So I think that's very important if you should have some succeed to treat this group of patients here. In this study, we will mainly look with this HIT training, we mainly look into the beta cell function. We'll be looking at insulin sensitivity, how this may change during this intervention study. We look also at the increased fat metabolism. We'll do some DEXA scanning on this, and then there will also be some cardiovascular system. However, we don't have the time to go through this in this presentation. So the aim was to demonstrate the effect of 8 weeks of low volume, high intensive training, where we looked at a group of diabetes patients, mainly on glucose control and pancreatic beta cell function. And just not to go through much in detail, but there was in the diabetes group, there was 12 included. One was excluded before we start up, and then there was 11 going to the intervention study, and 10 was passing through the intervention. And then we have a matched group of people without diabetes that have a tendency to have the metabolic syndrome, overweight, and the other characteristic, but no diabetes, of course. And there was 13 including, and everybody passed through the intervention here. The design of it, where we measured first BMI, and we took some oral sample, we made the oral glucose tolerance testing, we made an ICG, we made a VO2 max, and we make a DEXA scan for the body composition, especially to look about how the fat composition was changing. And then they went into the intervention for 8 weeks. They were training 3 times a week, half an hour only. They did this intervention interval training 10 times at 60 minutes. And then we, in the end, after the 8 weeks, we repeated all the measurements here again to see what happened during these 8 weeks. And here's some of the data from it. I will not go through just some of them, but we could see mainly it's people in the groups, both of the healthy subject and those with diabetes. There was, you see, people in the 50s that was included here. What we could see about the blood pressure, both the systolic and diastolic blood pressure, was in fact that we could see a significant decrease. Also, even here in the diabetes group, here, even they were on medication for high blood pressure. And just to mention, we could see the VO2 max, where also major changes only those 8 weeks here, significant decrease. And even when we modulate for the weight lost, we could also see that they still have very nice, significant difference here after the intervention here with the VO2 max here. I'll go through some of the data here with some figures. The hemoglobin C and hemoglobin A1C, we could see there was no significant difference from start to end in the group without diabetes. And the group with diabetes here, you could see there was a significant difference here in the hemoglobin C1. And when we looked at the fasting blood glucose, as plasma glucose, we could see there was no, and I'll not expect that either, of course, difference here in the healthy group, while the group with diabetes, we could observe a significant difference, and decrease in the blood glucose levels. When we did the oral glucose tolerance testing, we could see after the 2 hours test that the blood glucose was unchanged in the control group, and it was decreased in the group with diabetes. And when we did the oral glucose tolerance testing, we also measured the area under the curve. And here we could see there was no difference here in the control group. That was also maybe a little bit expected. But in the group with type 2 diabetes, we could see there were many points here where there were significant differences. However, due to lack of power, we were not able to demonstrate a significant difference, but there is a tendency that there was being decreased during this 8 week of intervention here. We measured all the first phase, also of glucose, and here there was, particular with the group with type 2 diabetes, there was a decrease here for this group here. And also when we measured the HOMA insulin resistant, we could also see very clearly that there was a significant decrease in the group with diabetes, and no difference in the control group. Finally, we also made a HOMA beta cell function analysis, and there we also could see we saw an improvement here of the beta cell function, who was significant in the diabetes group, while in the control group it was an increase but was not significant. We also measured the oral disposition index, and here we could in fact see an increase in the diabetes group, about 33%, and no difference in the control group. And when we, by the DEXA scan, could observe what happened with the abdominal fat, we could see there was a very nice decrease, particularly in the diabetes group, which was highly significant, while there also was a significant difference in the control group also. And this was also matched with the waist, and there we could also see that it was decreasing, also maybe more pronounced in the type 2 diabetes group. So out of this, we concluded that we could see, particularly in the diabetes patients, that the insulin, there was a decrease in the insulin resistant, and also we can see an improvement of the beta cell function. There we could see that the hyperglycemia was also improved, and especially we could see the first phase of glucose after the first 30 minutes after the intake of the glucose load, that there was a particular decreased in the type 2 diabetes group here. And also we could see that the fasting plasma glucose after the oral DCT test was decreased in the diabetes group, while there was no difference in the control group without diabetes. And finally, the abdominal fat mass loss was also decreased, and also the waist was minimized in the diabetes group, but also we saw some nice results, in fact, also in the control group. So what we can extend out of this is that maybe this new training method maybe be interesting, especially to make new strategic ways of training diabetes patients, and it could maybe also it could be inspired to a new change of guidelines for training diabetes patients. We're still going on with some analysis at the moment. If we look at inflammation, that's what we're doing now. Particularly, we're looking into circulating cytokines and different kinds. We also look at the vascular function, epithelium-dependent flow, mediated deletions, and we're also looking at the moment, which we hope also we can demonstrate that this way around that we may avoiding and delay the case for amputation of this group of patients here, which have about 80 times higher risk of amputation than the normal population. Thank you very much for your attention.
Hi, good afternoon. My name is Swati. I work with the Almond Board of California, and I've had a very good time listening to all of you this afternoon. Thank you for very informative presentations. My question is, actually I have two questions, and they're both regarding the DARE trial, First one being, was I correct in understanding that in the combo arm you actually combined the time for both resistance and aerobic? That's not the question, that's just an understanding part of it.
Yeah, it's
okay.
Not my trial, but yeah, that's what they did.
Okay. And what is your opinion in terms of if they had kept the time constant to 135 minutes and then combined, say, made it half aerobic and half resistance, where do you think the data may have ended up?
I suspect it would have looked a lot like what we saw in Heart D, because that's what we did. That's what we saw.
Oh, okay. So maybe I missed that.
Yeah, so I mean, they had much larger changes in hemoglobin A1C. I suspect it would have came closer to ours, but I'm just guessing. But yeah.
Okay, and then the second question was more about combining or planning to combine maybe a dietary intervention with one of these trials to see how that may or may not work.
Yeah, I actually think that's a great idea. Getting something like that funded is next to impossible, unfortunately. So much of this is not driven by science, it's driven by what you think you can sell. And that would be nearly impossible to sell, unfortunately.
Okay, thank you.
It seems to me that at a trial like that, you know, combining maybe a Mediterranean diet, you know, which has a lot of evidence, would be something that would be, you know, very attractive. Again, the key is going to be who's going to fund it.
Sarah Madavi from Toronto. I just want to thank all of you for a fantastic presentation. I did my master's in exercise physiology, so I was so excited to see exercise talked about here. I have two questions from Dr. Church. First one is that, so your main outcome that you looked at was hemoglobin A1C, and you mentioned that a lot of the subjects were on medication. So my first question is, what was compliance for medication? And second question is that you mentioned hemoglobin A1C was measured every month, but that's not, to my understanding, validated. Hemoglobin A1C is supposed to be measured every 3 months. So if you could answer those two, that would be awesome. Thank you.
That's a great point. I really screwed that up. So we took a very different stance than they did in DARE, and our stance was their physicians manage their medications. We don't tell them anything about their medications, and we very closely track their medications. And what we actually saw is in the combination group, they reduced their medication use. In the control group, they increased their medication use. This is why it's such a joy to do study in people with type 2 diabetes. And, you know, yeah, we tested every month. We weren't following clinical guidelines. We were doing the best research design. And there was a safety element, too. There was a safety mandate. We had to make sure that we weren't hurting the control group. So that's why there was both monthly testing and laboratory testing, which was at the beginning, at the end.
Hanna Kaleova, Czech Republic. Thank you very much for wonderful presentations. So what about interval training? Is it more effective in increasing physical fitness and in improving diabetes management?
Yeah, you must say there's not so many studies done on this one, so that's why I was one of the first really looking at particular type 2 diabetes. Our focus had mainly been that we could keep the people and the patients continue the training afterwards. And if you're using too much time, you know, just like when you have to go to a nutritionist and the people get many good ideas, but how to maintain it afterwards, that's the problem. And here it's only, you know, this is 3 times a week, half an hour each time, then you're done.
You know, I think in my opinion, most of the exercise experts in the world think that high-intensity interval training, or HIIT, is better than moderate continuous training. And certainly there's lots of small studies that look at either just fitness, improvement in fitness, or some other measure of cardiovascular structure and function, all typically show that the HIIT does better than the moderate continuous training. The problem is, and we have a state-of-the-art review that's going to be out next month in Circulation Research with the 3 of us and 8 other authors that are all pretty big-name exercise people. And we discussed all of this, but the fact is that there's no trials that have looked at major clinical events with HIIT. And no trials have looked at long-term efficacy and safety. And so a couple of my co-authors and I did a review in heart failure just a couple of years ago of all the trials of HIIT versus moderate continuous training in heart failure. And we came up with about 110 patients in the world's literature that was published 2 years ago. So there's not a robust amount of long-term data with hard clinical endpoints. And without that, it's pretty hard to make a guideline to say high-intensity interval training should be the standard. I would predict that it would come out better, but I don't think we know that for sure.
I don't agree with him. You know, we don't treat high blood pressure with one medication, and we don't treat diabetes with one medication. These are now 2 and 3 medications, diseases commonly. And I view exercise as medication, and I view weight training as one type of medication, and I view long, slow aerobic as another type of medication. I view higher intensity as another type of medication. I think the best program combines all of them. I don't think that HIIT is the best program, or LSD, long, slow distance, is the best program, or weight training is the best program. I think in the perfect world, they're all the best programs. A program that incorporates all of them is, because that way you're stimulating all the different physiological mechanisms and maximizing benefits.
I have to continue to correct my junior colleagues. I know the best exercise program. It's the one you will do.
Hi there, John Stephen Piper, University of Toronto. I just want to thank the panel. It was just really an outstanding session, really inspirational. I just wanted to make a comment because it came up. We're actually going to hear on Friday about the PREDIMED Plus trial, which is the Mediterranean diet plus exercise, the rationale and design for that. So that is ongoing. They're still recruiting. And we will be having a planning session, so this is just plugging our program, for the Enhanced Portfolio Lifestyle trial, where we're combining the portfolio cholesterol-lowering diet with low glycemic index and load with exercise. Right now we have a pilot study that'll be 3 years looking at atherosclerosis with MRI and ultrasound measurements. And we're hoping to recruit centers, including the centers of our esteemed colleagues at the panel, to participate in the larger clinical events trial. Just a comment, thank you.
There was another one up here, yes.
Anastasia Thanopoulou from Greece, thank you. What did you see in the self-monitoring, blood sugar monitoring during the resistance training days and versus the aerobic training days?
So we didn't, that was, the way we did that was we would check it before they exercised, and if it was too low or too high, then we either held them out or restarted it. We didn't, it just was too much data to look at that, to look at the self-monitoring stuff. I mean, we had close to 300 individuals to have 3 or 4 self-monitoring. I wish we had looked at, the problem with monitoring, self-monitoring is everybody lies to you. And they're all going to tell you they're self-monitoring in the beginning, and they're all going to tell you they're self-monitoring in the middle, and they're all going to tell you they're self-monitoring at the end, and we know they're not. So we don't have very good self-monitoring data. That's the bottom line. That's a great question.
Okay, and maybe this will be our last question. Thank you.
I'm Flora Wen from Toronto. Thanks very much for your talk, and I very enjoyed very much. Just have a question. When you put your subjects on different treatment regimens, did you look at their background diet to see whether, say, macronutrient composition would differ, or if they actually help if they were on a certain type of macronutrient distribution, or it doesn't really matter? Thanks.
You know, it's not, we do, and we do the best we can, but as most people know in this room, unless you have doubly labeled water or people come live in your institution, people lie about what they eat. And when we did Heart D, we were at Pennington, so we had some of the best nutritionists in the world working on this, who weren't typically part of our exercise team. And as usual, we saw everybody reporting 500 less calories consumed over the course of the 9 months. So the nutrition data, I've never seen it not just border on fiction, or actually be anything other than complete fiction. And we got a big eating trial going on now. We're using doubly labeled water, and it's totally awesome. But that doesn't tell you what they're eating. It just tells you they're eating more, they're eating less, unfortunately.
Dr. Lavie, did you have a paper on that published yesterday?
Mayo Clinic Proceedings, June 9th, 2015, talking about the dietary data and how they're utilized in the new guidelines. Ed Archer is first author.
There's your reading, I guess, for this evening, perhaps. So I'll just remind you, meet in the lobby at 6 o'clock this evening for the University of Toronto tour, and meet in the lobby at 6 o'clock in the morning tomorrow for the Moore Park Ravine tour. And please don't go. Here's Dr. Stephen Piper.
No, just to modify that, for those of you that want to get some exercise after this wonderful session, we meet at 6 o'clock, and there will be the tour going out to do the insulin tour for the University of Toronto.